All right. Good afternoon, everyone. My name is Dr. Kendra Lee. I'm the Associate Director for Access. Welcome. We are so glad to have you here today. This is actually our third Veteran Access Forum. And so, what we like to do in these forums is give our veterans an opportunity to speak with our Access team. Who all is a part of our Access team? Glad you asked. That includes our community care, it includes our health administrative services. It includes our outlying sites of care, and it includes our group practice managers. So you'll have an opportunity to hear from the leaders of those particular service areas, and you'll be able to ask them questions and get clarification. Now, what I do want to caution is during the forum, we are recording and this information is being live streamed. So we don't want to have any of your personal information shared across the masses. So if you do have specific questions that are unique to you or your personal information, please feel free to reach out to the service, the folks that are in the room directly after, and they can address that one-on-one. If you're online, please just leave your name and information, and we will make sure that we follow up with you after the meeting. So again, please do not share too much of your personal information, no socials, none of that. We can meet with you one-on-one afterwards to go through any specific information for you directly. So there's some updates that I want to share with you all and that I'm excited to share. First and foremost, can we go to our website? So the Access team has heard that we need to do a better job of communicating with our veterans about access. And so what we've decided to do is we've developed a website. It's still new, so we're adding a lot of content to it now, but it has information for our veterans to be able to know what's going on within community care, HAS, and all the other service lines that I mentioned previously. So each of them has a section on the website. You can click community care, the plus sign. Yep. And then it'll have some more information under each section. Again, we're still developing it. We're still adding information, so bear with us, but we have at least got the website up and running. This is something new for the Access service, and we're hoping to use this as a tool to get information to you guys more directly and a lot quicker. There are a lot of changes that are coming through the Access teams that impact community care and how you get care in the community, as well as here at the facility through HAS. And we want to make sure you guys are getting that information directly. So this is a great way to interact with our team. They'll provide updates and ways for you to communicate with them through this portal. So please, if you get a chance, please explore. It's on our main website, so you can find it directly from the Atlanta website, the Atlanta VA Healthcare Systems website. But we did include the link, and so when we shared the slides for this session, you'll have access to that. Next, I wanted to share that we are working on our phones. Since I've been here, I know that being able to reach out and get a person has been somewhat of an issue. And so we have a plan in place to address that. What you see here is our directory. Now, this is internal. It won't be for you directly, but what we're starting with is updating our systems. And so this was actually set up by one of our GHAP interns. A GHAP is a student that is going through a master's degree program, usually master's in health or something along that line, that we bring on board to develop, and they each get projects. So that particular year, our GHAP developed this directory, and it will allow us to better figure out how to contact people and update all the information, so that it will improve our ability to make sure you get to the right person, or that we connect you with the right service line. So you get less of answering machines and more of direct access. We are looking at how we can get you to different service lines versus a person. So for example, if you call in and you need to talk to a doctor, during the day, we expect that the doctors are providing care, right? But we want to make sure that doctor gets your message and is able to follow up with you in a reasonable amount of time. So the goal is to know the correct point of contact for each service line to be able to get those messages to the right person and ensure that they follow up with you in a timely manner, instead of sending you directly to the doctor that we know is in clinic and is taking care of other veterans. So we are working on this process. The goal is to have it up and running and much better by the end of in the next couple of months. So by the time we have our next meeting, I will have additional updates about our phones and what we're doing to improve that for you all as well. And last but not least, we are developing business cards for our MSAs. Our MSAs are those folks that you meet when you go into the different facilities. They're the frontline staff that check you in, take your information, and usually they may give you a sheet of paper to say, hey, Mr. So-and-so or Miss So-and-so, if you have any additional questions or any concerns, this is how you can reach me. We want to make it more easier for them to do that. So we're getting them business cards that they can put their information on that you can keep and be able to get a person if you need a person in the clinics that you're going to. So we're looking to get that rolled out. We've already sent out the prototype to get those developed. Once we get them back and approve those prototypes, they will be out to our MSAs. So you will see that change coming through. So these are just some little things that we're doing as a team to make sure that we're improving our communication with you guys. We're getting you information timely and updating you with all of the changes that we're getting, because we know that there's a lot of changes coming quickly. So thank you again. Welcome. So glad you're here. And I will pass it on to Community Care. Dr. Hollis.
Hi, I'm Elizabeth Hollis, and so I am with Community Care. I am currently the acting chief while we await to see who will be our new chief. And so then if I am not the chief, you will see me always in the clinical nurse leader role as the chief nurse. Okay. All right. So we have a lot of questions and a lot of concerns about how do I get a hold of Community Care. We have long wait time. I hang up, I call back. It's even longer. I sit there and wait, then it hangs up on me. And now I'm frustrated. So we're talking about this again because this is one that I like to get out to the veterans to let you all know the best way to contact us is secured messaging. Ask Community Care a question. Why? Because we got to respond to you in 3 days. I know you're calling through on the phone. I know you're trying to get through to talk to a live person, but what you can say in the secured messaging, if you want to speak to a live person, is say, please call me. I need a call back. Please don't talk to me through secured messaging. The best time to call me is, and give me the date and the time that the best time for the MSA or the nurse to call you back and find out what's going on. Okay, because not everything can be resolved through a secured message. I get it. But our phone lines are brutal. We receive anywhere between 700 and 1,100 phone calls a day. All right. And so what's happening is when a veteran calls in and you're frustrated because we haven't answered in 10 minutes and you hang up, that's an abandoned call. It does count on our measures as far as that. And then you call right back, hoping to be able to get into the line and get it through faster, but it's not faster. So if you find you're not able to wait, secured messaging, ask Community Care a question. And guess what? If your question isn't for Community Care because you want a consult to be able to go see physical therapy because you hurt your shoulder when you went to the emergency room, they said you needed it, we will then forward that to your primary care provider and let them know you need to respond to the veteran. He needs additional care. And then he or she can make that decision of what's going to happen next. All right, so ask Community Care a question. There's also Ask Atlanta Community Care a dental question. All right. And so that is for our dental team in Community Care. And we do get a lot of questions about our dental in the community as well as internally. Some veterans want a consult but have never been seen. There are specific eligibilities that have to be met for you to get dental care in the VA. All right. So I don't know specifically what all of those are, but that is required. And so I would then forward your message over to the chief of dental and over to your primary care provider so that they can take a look at that and see what needs to happen for you. Okay. Ask Community Care a billing question. All right. And so you'll see it says ask Community Care billing _admin. This is where you can ask, hey, I received a bill. All right, but I call caution. Make sure you read the bill because I have a veteran at home that I can't walk away from, hang up on. I have to see him every day at the dinner table. And so when he got upset because he's like, I got a bill from Community Care. And I'm like, I'll be home in 10 minutes. When I walked through the door, I took the paper from him, looked at it, and in the middle of it, it said, this is not a bill. Okay. And so when you see it and you see the number at the bottom, it is shocking because you're like, I am not going to be paying that bill. And so I get the anxiety that comes with it. So make sure you look at it. When you open it, take a deep breath, then look, take it away, look at it again, and look to see if anywhere on there it says this is not a bill, because you will get notified from companies that you've received care from That will tell you what the cost was for your care. And then you'll receive a document from CCN, Optum, that's the network, that will tell you what they paid for. And that usually comes in after. Sometimes it crosses, sometimes you get it on the same day, sometimes you might not get it at all, but you will receive something that'll tell you how much to pay. So take a look at that, and just know that you can always call, but the best way is secure messaging. Why? Because I need a copy of that bill. Okay, that's very important. My team needs a copy of that bill so that we know who to call in billing, get to them, have your ID number that's on there as your patient ID number, and then we can say, why are you billing the veteran? Okay, and why are you doing this when you have an authorization? Things get crossed. People pick up from the fax machine in these offices. There may be 2 or 3 different nurses and 5 or 6 different doctors. And she picked it up for me. I didn't know it was there. So I billed under your traditional insurance. Now you're getting co-pays and now you've got bills coming in. Okay. So you really want to make sure that you take a look at it. What happens if you get a bill? Let us know immediately. Send us a copy of it. Scan it in, take a picture, however it is, get it into secure message and say, I need assistance with a bill. We will immediately pick it up and review it. Okay. If you show up for an appointment and they tell you you're going to have to pay $96 for this visit, you don't owe a copay. Under the VA CCN network, you do not pay a copay directly to the provider. All right. And so with that, you should not pay it. And if they say we're not going to provide you care if you do not pay it, okay. So come back, send me a secure message, tell me you didn't get the care. They're trying to bill you a copay because I'll be turning around to call Optum and let them know wherever this care is being given from, they denied the care to the veteran and they wanted a $96 copay. Not appropriate. If you owe a copay, it will not be to the community, not under traditional insurance. All right. And so what happens is if you owe a copay, it's based on your eligibility and enrollment in the VA, and the VA will send that to you. Much like I'm not sure if you get a pharmacy bill. So my husband will receive a pharmacy bill and it'll say he owes $20. He got his medicines for whatever. We'll pay it. That's whatever it is that's decided internally. So please, when you go to the community, if it's dental, if it's mental health, if it's regular medical, you do not pay a copay. Right? So what's happening is someone is not looking at the authorization of VA request. They're looking at your traditional insurance and going, oh, you owe a copay. So the example is veteran Hollis was going out for a CT scan. And he was there, and I couldn't believe he had listened to me all these years in community care about you don't owe a copay. When Wellstar called, they said you owe a copay, and he said, oh my goodness, who's asking for the care? And they named his VA provider, and he said, oh, that's my VA provider. I don't owe a copay. So they stopped, went and verified, came back and said, you are exactly right. Thank you. We'll see you on this day. So just know that's one way you can advocate for yourself. If they call you and say, we would like for you to come in, we've got this appointment for you, you say, do you have this under VA pay? And if they say no, we put it under your TRICARE, we put it under your Medicare, your Medicaid, your Blue Cross Blue Shield, whatever insurance you have, and you know it came from the VA, tell them that is incorrect. Okay. And so we can move it from there. So that's the best advice I can give you about that. All right. Community care phone number is 404-321-6111, pound number 6. But again, we get a lot of calls every day. We are making adjustments on those calls. We are trying to be a lot quicker. So when you call, the first person you're going to speak with is an agent that is going to say, how can I help you? You're going to say, I need to talk to somebody about billing. And they're going to immediately transfer you to a vendor relations team member. Or you may say, I have a community care consult and I want to be scheduled because I've been waiting forever and I want it. All right, let me send you over to an administrator that's going to help you get scheduled. Okay. So that is the number for us. But again, the best way to get a hold of us is secure messaging. Okay. All right. Community care bills. Here we are. You do not pay a copay. If you want to take a picture of this, you can, because this is for the directive. All right. So you do not pay the bill or the copay. If they are sitting there saying, we're going to send you to collections, you say, great, community care, you're up. We're going to step in, we're going to take care of it. All right. And we have had veterans that didn't know this information and were sent to collections. And we have been successful at getting it stopped, reverted, and corrected off of the veteran's, credit score. All right. And so if you have any of this going on, I need the bills. I need to know who's doing it. And I need to know where you are in the process if that has happened. If you are already at collections, I need to know that immediately because that should not be happening. Right. Next page. Bills and non-covered services. This one is also very important. Community care does not pay for FMLA or Department of Motor Vehicle forms to be filled out. That's not it. All right. If you need an FMLA form for wherever you may work or Department of Motor Vehicle forms to be filled out, your providers in the community are charging. All right. So I needed a form filled out and they charged me $35 for it. I almost fell out of my chair. I was like, no way. So it was one page. I could have done it myself, but needed their signature. It's terrible, but it is what it is. So the DMV, FMLA, work or jury duty excuse. So if you go in and you're asking for these forms to be filled out and they tell you it's $75, Optum does not pay for that. That is on the veteran. All right. And so that is considered an ancillary service. Some providers will fill it out for veterans, but they're not obligated to do it for free. And so it's whatever they've mandated in their office. We do not control that, but we also do not pay for it. So the best thing to do is to bring those forms to your primary care provider here at the Atlanta VA and ask them to assist. And if you live far and you are trying to get to that a provider, also send a secure message with the forms uploaded and say, I need these filled out, please. And they can take care of it from there. Okay. All right. The acronym slide. So I am trying to make sure that I don't talk in code. We all know how that goes, and I can do all day in community care because everything is the OIG, the IVC, CCN, Optum, So DMV is Department of Motor Vehicle, FMLA is Family Medical Leave, and the CCN program is called Community Care Network Program. So I'm going to try and be more mindful not to talk with all those acronyms. Can't believe after 10 years I've got them all straight, but I got them. And so I want to help you all understand when we're talking too, because sometimes we forget when we're talking to our veterans that you all have no clue what we're saying. And so we've got to make sure that we get the info out there to you of what are we talking about so that we can better help you understand your care and get your care taken care of. If you have a consult or think you have a consult in community care and you have not heard from us, I have two of my agents in the back that can help you right now. That is Mr. Daryl Baker and Miss Shayla Smith. And so if you wish for them to take a look in the system to see if you have it so we can address your concern today, I have them available. All right, questions? I know you had your hand up.
Going back to getting ancillary care at a provider. I mean, a lot of times you may go and, oh, you need this test, you need that test, and so do the test, but you don't know if it's part of the VA referral or not, and they're not discussing that with you, they're just doing it. And then you're on the hook for it. How do you avoid that, or how do you?
So we have what's called CEOCs that will cover that generalized care. So if you go to a primary care provider in the community because you meet for drive time, we send you out there and he says, oh, you're going to need some blood work and let's get a chest x-ray and let's do that is all built within the CEOC. So what veterans also don't realize is if you have an orthopedic consult out in the community, the CEOC actually gives you 15 physical therapy appointments. So we have veterans that'll call back, y'all never called about my physical therapy, but it's actually to the provider in the community. It's already approved. All they have to do is make sure they're within network for physical therapy and you can immediately start. A lot of people don't understand that. So that's why we're doing these access meetings, because I'll be taking your question and probably moving it to more of a teaching opportunity about our CEOCs and what is covered under the care and what is not. What is not covered from a primary care physician, hey, looks like, some of your white cells are a little high. I think you might need to see an oncologist. that requires a request for service to come in because you can't just go see an oncologist. You need another authorization. So that has to be done. But as far as like lab work and x-ray, your primary care provider could do that. So it just depends on the consult. Do you have one specific?
I was just looking back at some of them, and you brought that up, and I know it happens quite a bit. I know it happened to my son, they just did the test. Um, He's not a veteran, but it was a blood test because his wife was pregnant. And they came back with a bill of $5,000, they didn't tell him that. But, well, they don't discuss that up front. A lot of times doctors will do that.
And that's because the provider doesn't know what insurance you have. They don't know that you're coming in as a veteran. They may know you're a veteran after speaking with you, but they don't know you're coming in after VA. For us to be the payer source. That's the back office people. So you really got to stay tight with your back office people. And as you're walking out the door, you say, hey, I need to know if this is actually covered, and they should be able to look at it because they can go into the system and see it. And if they can't, then of course you can call us, or I'd much prefer secured messaging so that we can quickly document it and get that answer over to you.
Some of the referrals have different services, and they'll say like number of authorized visits, for instances, and they put 99. I'm assuming that means unlimited.
So that means
The provider.
correct. So well, sort of. So what it means is there's 99 visits there. So under orthopedics, it used to be 180 days. And what a challenge that is, that you're about to have surgery and your auth is going to expire 20 days before you go in, and now you need a new auth. Now the authorization is 365 days. So if the provider does surgery and needs to see you in 2 weeks, you can go. If he needs to see you at the 6-week mark from the time of surgery, you can go. If he wants to see you in 4 months after the surgery, you can go up until the authorization expires. You can go back in and see that provider. So it's really important that when you receive a consult, you also make sure that we're sending you the authorization packet, and it will tell you what you're going out for and what the authorization letter is. And it should also indicate your expiration date, because you should know what the expiration date is. That way, if they give you an appointment on April 1st and your authorization expires on March 30th, you don't go to that appointment because it's not covered. Then you end up with a bill, and then you're upset with us, and then we're trying to figure out what happened, what's going on. And we do not backdate, okay, for care. So then the providers get upset and it's a whole mess, but we're working on it. Yes, sir.
When secure messaging fails, why?
So secure messaging can fail because we are so inundated that it may take us 4 to 5 days. Sometimes it takes us 6, but our leadership has come down to say no. And so every morning now, our medical center director requires the report out of where are we in our secure messaging. And so community care has taken that challenge very seriously. And this morning I had 1 over 3 days.
So when did that?
That actually began, so I returned to duty the first week of January, and we have been compliant the entire time. For community care, you think we're outside? Well, let's talk about that after.
I'd like to.
Yeah.
Yeah.
So-
Multiple messages to your team, 0 correspondence back.
Are you
That's the-
for community care?
Yes.
Okay.
Community care, I've also gone and spoken to the patient advocates multiple times about it via phone. Most recently was in person on January 9th. I've not heard a word back from either team.
Hey, Mr. Baker, will you please pull open secure messaging so that I can walk back there with this gentleman and let's take a look at his messages? Thank you. All right, and we'll take a look at that. But I did only have 1 this morning, and we are working very hard. So it also depends on when the messages are coming in, but I'd like to look at that because I want to know.
Messages over a period of weeks.
Okay, we'll take a look at that. Absolutely. I appreciate you letting me know. And I know that Dr. Lee is also appreciative of it because we want to be better.
I understand that, and I'm trying to allow for that to happen, but it's been so problematic in community care specifically for years, and I'm trying to allow that. And even in my messages, I referenced, I believe it was Ms. Lee, a couple months ago with the Access Forum, in addition to the director's last town hall discussing the 72-hour policy and just watching it expire day after day, and then setting another follow-up and watching that expire day after day, and then reaching out to the patient advocates probably 4 or 5 times and watching that expire with no correspondence. And this is the same sort of thing that has been happening for years. And I know that you guys are trying to change, and there has been a lot of positive things. So I'm not trying to beat you to death, but when I'm still seeing the exact same thing, and it's, oh, just use secure messenger, but that's not happening.
So let's take a look at it. I'm very interested because there are a lot of things in community care that we need to fix, change, improve, speed up. So let's go back and take a look at that. I appreciate you telling me.
Sure.
Okay, and then we can take a look. All right. All right. Any other questions?
If you're sending a secure message, and it may be community care, maybe somebody else, and they refer your question to another department, another doctor, does that start a new clock?
No.
Or is this
Nope,
just
same
there?
clock, same clock.
But there's some that have been referred by primary care, and you just kind of gone there, sitting there, but it's coming back.
So I would like to say, primary care has been struggling with their secure messaging. We have a concerted effort, and so they've changed a lot of their processes so that they can do a better job. There's still a lot of backlog, so we're still catching up from that end specifically. Now, with your situation, again, we're interested to see what happened, to see if it's a one-off, that there's a glitch that we don't know about. So this might be the first time. And what I will tell you is, some of our systems are not perfect because, again, secure messaging is still a fairly new system at the VA, right? And so we don't know all the ways that it can fail and all the ways that we may miss a message. So I'm interested to see what happened with yours particular, because I do know that for the most part, and again, we're not perfect, most of our messaging we are receiving and we are responding to. So if there's something that's different with your messaging, especially if it's happening in different areas, that sounds like there's more of a concern there with what's going on, and there may be something additional that we need to look into or check for going forward so that we can ensure that this is not happening.
Well, and so that's kind of my, like my next follow-up question, and we can talk about that offline, but, whoever the hiring manager is for these MSAs, because, when that fails and you reach out to someone and you get hung up on,
It doesn't make it any better.
sure doesn't.
Exactly.
It sure doesn't, and it doesn't make my language better. And then they try to project that I'm the problem when the system has failed. And you can leverage internal policy, but that doesn't outrank the charges from Congress to perform this work, right? So
the other part of this is culture, right? So the other aspect is we are working on improving our culture here. We are putting in some expectations for our staff that may not have been in place before our new leadership got here. And so it's going to take some time for that to trickle down and really show fruit, because you don't plant a seed and it grow overnight. But that is something that is our priority. That's not lost on us. So we are very aware of your frustration, and every time we hear about things, we're now looking for a new way to fix it. So not only will we follow up with you about what's going on and we can then track it, then we're starting to see, okay, are there other people impacted? What else are we missing? So there's a lot of things that we don't know. And that's part of the reason why we set up this forum, so we can have these conversations and get your frustration so we can fix it, not just let it linger and not realize that it's going on. So we want more of the feedback. We want you to tell your friends. We want to fill up this room so that we can answer those questions and address your frustration, because to be honest, your frustration is our frustration, because we don't want that to happen. Our intentions are never to leave our veterans high and dry. We work with them, but we have veterans on our team. They're just as adamant about the care for their brothers and sisters as we are. I'm a military brat. I grew up on installations. This is not just for performative conversation. I have a genuine interest to make sure that you're getting what you need on a regular basis, not that I'm just meeting what Congress has. I don't know anybody in Congress, but I do know you. So making sure that you're getting your care is our priority.
This entire situation, right?
And we're not mad about that, because again, our goal is to figure out what we're not doing right so we can fix it. And I don't think that there's a one size fits all.
Sure.
But I do think that as long as we keep trying, we're going to get to success. And so these forums are for the very reason of figuring out what we're still not doing right, how we can fix that, and being accountable to you all as veterans so that we can come back at our next forum and say, you brought this to us at the last forum. So we went, we dug into it, we got more information. This is what we found additionally, and this is what we're going to do going forward. We're trying to get in front of the problem and not always be behind. And I think that has been some of the problem in the past, is that we've always been trying to play catch up. And again, that's not solving the problem. That doesn't make it easier for you as a veteran. It doesn't get your care faster. But if we start having this open communication and get things sooner, we can then dig into it and then follow up with you and make sure that we're solving the problem and not just masking a problem.
Yeah, and I appreciate that, but I think one of the things, like from a veteran perspective, that might be a little different than like a military brat perspective, is that over time this starts manifesting in physical problems
Mhm.
and health problems. And how can your core provider be the reason why you're having addiction? Like, that's crazy town. So I hear it, but it's still a little bit of lip service because I am reaching out to these things. And I am trying to be cool about it and figure it out and help you guys figure it out. I've offered to come work here for free multiple times over the years. I'm not seeing it. I'm not seeing it.
And I don't discount what you're saying. I totally agree. I think that there has been so much change in this facilities, particularly over time, that there hasn't been consistent and steady leadership to actually get to the results one way or another. And I think that adds to the problem. Also, my father is a veteran. My father would not come get care here until I actually brought him. And even then, he did not come back until I came here. And so I've worked at several VAs throughout the country, right? I've been able to impact several veterans throughout the country and their concerns and address things. So coming here, I knew that there were unique situations and issues here in Atlanta. And so I wouldn't bring my father here if I'm not going to put forth the effort to make sure that it's what he needs as well as other veterans. So again, this is not just lip service. My veterans get care in Business 7. I have an aunt who's in Army. I have her husband's Army. My dad was Air Force. My uncle's Navy. They're all within this region and they're all getting care. And so this is not just for show. It's not for Congress. It's because I truly, genuinely care. And I'm showing that because I'm bringing my veteran to make sure that they're getting care. And most of us, either they get care here who are employees, which they don't have to do, or they're bringing their spouses and their loved ones to get care here. So it is in our invested interest to make sure that we're improving the system, not just for you all, but also for our families too. It's a systematic thing. So again, we really want to get with you and make sure that we address your concern, but we also want to make sure that we're addressing it for all of the veterans too. Because if you're having this problem, that means other people are having the problem.
Here.
And so we thank you for that.
Yeah. If I have a heart attack about it,
We don't want that.
you guys earmark this little visit we had.
And we will make sure that you don't have a heart. We'll get you with whole health and all the right people because we have
I
providers.
already met them.
Okay,
Did nothing.
all right. Yes, sir.
What if I just started using the VA system in the past, and your initial visit to the facility doesn't go absolutely great.
Mm-hmm.
So now you come back and you try to say, okay, well, let me talk to somebody, and you call patient advocacy.
Mm-hmm.
And you tell them specifically, I'm afraid for my life with the care that I'm getting. And they blame the situation on me, like I was the problem. And all I wanted to do was to change my provider from one location to another location. They told me they couldn't do that.
So they might not be able to do it, but we can. So we can get you with HAS or community care, depending on where you're getting the care, and they can help get that switch. So that's not a problem.
I told them, I said, I'm afraid for my life. I wouldn't go further.
So I will address that with the leadership. I'm on the ELT, so I will go with the ELT and we'll address that. And then we'll get your information so we can follow up with you. That is not a problem. Yes, ma'am.
This is already, but who dictates and determines how many visits that you receive per specialty? Or like an external consult, like in specific, I'm concerned about like maybe acupuncture, and I know physical therapy is pretty specific to if it's a knee, or knee replacement, like I can understand if that's generalized and specific. But when it comes to something like acupuncture, which is something that we don't necessarily utilize within our system, like who gets to dictate that? I've gone from like 50, 30 to 12 to 8. And that's a problem because there's relapse in between there. That if you're not asking the questions when you go to an acupuncturist, you don't know. You don't know what's happening to your body. So I want to know who dictates and determines how many we do receive.
Congress. And so what happens is the CEOC is developed, they agree on what's going to be on that CEOC and the number of appointments. So your first visit under acupuncture may be 60 minutes and you loved it. And then your next one's 30 minutes. We don't make that determination in community care. That's actually built within the CEOC. We have no control over that. But they did change 30 consults to give you 365 days. Let me tell you, the nurses were super happy about that. Because when you have breaks in care, you relapse and it's not good. So I'm very excited. And so I would say probably petition with your congressman, here in Georgia, ask them if there's any way they can start taking a look at it. I've often questioned, why do we have to relook at this after 8 visits for acupuncture in the community? They want more visits. When you can go under private insurance, such as Blue Cross Blue Shield, they'll give you 45 visits a year for a chiropractor. But we have to do it every, 12 or 8 visits? I forget what it is. So why can we not kind of mirror more of that? So I would say get with your congressman and see if they'll maybe change it. How great would it be that you could have 45 visits potentially in the community for a year? And then once you use up those 45, you're not eligible anymore. And of course, you got to come back in with an RFS and you got to be looked at again. But at least that break in care isn't there. They're always looking at ways to improve. And so I feel like they really heard the nurses when we were sending in a lot of concerns to the OIG and we're letting them know the breaks in care are not good. This RFS process isn't healthy. We don't like this. And then we saw where the change happened, that you've got those 365 days now. That's what I would recommend, but community care does not make the decision. It's already built into that care. We just attach the CEOC and that's what it is. For, for some consults like orthopedics, it used to be 180 days and we would have to ask for a request for service and it would be a break in care. Maybe you were planning for surgery and now you can't go to surgery because we're in the middle of the RFS, breakdown and we're trying to figure out where is the documentation. So 365 days means, let's say you get authorized in your first visits on February 1st of 2025. Then your authorization goes 365 days. So you can continue that care without having to come back to us.
Versus visits.
Yes.
I get the difference with that. But also, like, who initially approved, did Congress initially approve us for community care? And who sent that directive or that acquisition to Congress?
When you take a look at the CEOC and the field guidebook and IVC and everybody that's out there, it's written in the scheduling directives. And so with Mission Act of 2018, that's what's driving community care. And so all of that literature is online, or if you want to send me a secure message, I can try and give you all of that. That's not a problem. All right, we'll find the directives because I do have them on my laptop, but I can get those. And I'll try and remember to bring those the next time as well. And then with the access site that's going up, they said some forms can go there. I'll possibly look at seeing if I can put Mission Act on there and make sure that it's the right one.
Ask that question because just one meeting talking about my one console is, I don't think there's enough for Congress to do. But I mean, and maybe the 20 in here, maybe we can get Congress to do it, but if the initial directive came from the VA itself as a whole, like, couldn't we do that again?
And we are asking.
Okay.
Yes, we do ask. The nurses are begging, please, we don't want to be doing this process every 2 to 3 months. We want to be able to not have to upset the veteran and break the care. They are listening. It just takes time, and I'm hoping they'll get a little faster with it.
So, to her and this whole conversation, are those data points tracked and published somewhere? So that when a veteran wants to reach out to their representatives, they can use some analytics for their business case? Because that directly impacts your guys' ability to field calls and response times, and, you know, it's all tied.
I do not know how to answer that. I will have to check. Let me check on that. I'm sorry, I don't have an answer. I apologize. But, you know, things in community care, they get better and then we kind of stall and then they get better. But I do know that there is a lot of work going into community care. And if you will watch Congress, they are doing a lot of you know, different items for community care. So, for example, I believe it was yesterday, Congress had the VA secretary and finance person, I believe, and they were doing a whole inquisition about, you know, how much money they were spending in community care, because there is a look and a request to spend $1 trillion in community care to improve access for veterans. So there's a lot going through Congress. I try to listen, but I don't catch it all. So there's several of us, even at the vision level, that will sit on calls as we're driving home in traffic to try and listen to what's going on. And then we share the YouTube sites when they get posted so that we can try and listen to what are they saying, what's coming, how are they making changes, what do we need to brace for impact, what's coming for us. So not in a negative manner, but I do think Congress has a lot of vision for veterans receiving care and access more timely than what's been given in the past. I do think it's happening. I just think it's going to take a little more time to get to what I would like, which is 45 visits for the whole year. So you make the decision and you can't go past 45 visits, but that you don't have to ask for more and more and more. Hopefully that's my dream, that we'll get to that we can stop the breakdown with the requests for services. Okay, let me go ahead and get to HAS. I'll be in the back. And if you want to ask more questions, I'll be available. But let's get over to HAS and then I'll answer some more questions, okay?
Good afternoon, everyone. So my name is Venetia Daly. I'm one of the deputies for Health Administration Service. So you hear us refer to it as HAS. We have the centralized scheduling side of the house, which falls under me. So the schedulers and all that fall under me. And you also have the business side of the house that takes care of everything outside of the schedulers. So we're going to start out with the new Arcadia shuttle times. We aim to enhance the transportation and convenience to our veterans to get from, you know, specific locations. So right here, we do have our shuttle times. You can take a picture of it for those who do take the shuttle from the Claremont facility, which is the main facility here, to AVC, and also from Fort McPherson to the main facility. And we just ask that once you travel on the shuttle to and from these locations, that, you know, your return back, just coordinate with them there to know your exact return, because we are doing the return. We're not just going to leave you there. So this is a breakdown of the times that they leave each location. All right. So we have the Veterans Health ID card. You hear us refer to it as the VIC. We have extended a lot of our services to the what we call the CBOC, which is the community-based outpatient clinics. And each location have their dates and times. We ask that you reach out to the locations on the dates to ensure that the services are, you know, they're actually there. And we're pushing to make sure that we can validate that whatever date we say we're going to be there, we're there. And they're normally there from 9 a.m. to 2 p.m. At the main facility, we're here Monday through Friday from 7:30 to 4:30 p.m. That is in the Welcome Center. That is, again, Monday through Friday. We're closed on federal holidays and on the weekends. So how can I request a ride, right? So for the rides up here, we do have the telephone, the main numbers, the extensions. You can also take a picture of that. And we have our additional line that's up there. Now for the availabilities, we ask that you try to book your rides 1 week in advance. With the minimum of 3 business days prior to your appointment. They are also closed on the weekends and federal holidays. How can you request a ride? You can either do so in person, and the location is at the main facility. The desk is on the main floor in front of oncology, which is near the pharmacy. So on the same hallway as the pharmacy, you can do, you can request in person, you can request via secure message. If you don't have secure message, we encourage you to create your account. It is a identity verified account. So you can go to login.gov or ID.me to ensure that you are validating and creating your account for the transportation. So VH reimbursement, the caregivers and veterans, you can submit claims 24/7, 365 days. That's online. These claims are tracked electronically. And these claims are addressed promptly, but it do take 5 business days to address the travel reimbursement. Okay. All right. So we're going to talk about scheduling, how to schedule your VA appointment. So for primary care, dental, and eye, you can do the VA online scheduling. It's convenient to schedule. You can also request via secure message to your, your dental team, your primary care team, or the eye team, or you can do so in person. At any one of the desks, whether it's at the main facility or your different CBOCs, right? So we do encourage that once you have attended your appointment, upon leaving, to return back to the desk to schedule your return visit. That is the best way to ensure that you have your next appointment scheduled in a timely manner. So if you're discussing with your provider that they want you to return in 6 months rather than walking away, sometimes there's a line, but rather than walking away and then we have 50-50 chance of we can get you online or on the phone or not, you can go ahead and schedule right on the spot to get that taken care of, right? All right, for the transportation solutions, you can try next slide. Okay, so we do have some issues in Pike now to mitigate those circumstances in terms of the veteran transport service. We have partnered with Lyft to assist with the transportation concerns. We know Pike is kind of in a rural area, so they have partnered with Lyft, and due to the lack of Uber drivers in the area, Lyft will be used exclusively for Pike. So if you live in the Pike location, this is what will be used for transportation. And this is a way for us to enhance our transportation options for certain rural areas. So if we look at our no-show rate, we have compared with October 2025. We pulled this data for January, and up to the data in January represents our no-show rate for the month of December, up to the month of December. We were at 15% no-show rate, and at this time we're at 10.9%, which is a huge decrease. We're only 0.9% over the national goal. Despite our progress, we are still a tad bit below. So one of the things that we encourage you to do is to take action. Okay, so take action with us, partner with us, confirm your appointments. If you're not going to make your appointments, to cancel ahead of time. And reschedule right on the spot so we can have you set up for the next appointment. There are so many different mechanisms. We have our patient scheduling center, so you call in, you'll be able to take care of that. And what that does is it provides the avenue for another veteran who may be able to take that appointment. And if all of us as veterans, I'm a veteran myself, if all of us take that approach as veterans, someone may open up an opportunity for us to get an earlier appointment. So we're trying to work together to make sure that we provide that access to the care and reduce our no-shows. Yes, sir.
In regards to that, what happens if they cancel on you? Like recently I had a scheduled appointment. They canceled on me because of the weather. They're closing the office, which I understood. But they called me, which was great. But they said the next available appointment is 3 months out. And That, I said, you cancel on me, can't you get me in any sooner? And they said, no, this is the next available one. I've used the secure messaging to ask, hey, this is what happened. Can I get an earlier one? They said, no, you got one. I thought we have.
Okay.
And other clinics were 2 and 3 months out.
So I do know for primary care, I'm not sure if it's primary care or a specialty clinic. Okay. So for specialty clinic, I know certain options could not be made available as with primary care with VVCs. The providers, they were charged with ensuring that whenever we have to cancel an appointment, the business rules do dictate for patients to be seen within 14 days. So quite often the MSA will schedule you, but still send a message to the provider to say this patient has been canceled. We cannot get them in more than 3 months out based on your access. How can we work to get them back in? So the MSAs are having the conversations with the providers. Hey, this person needs to be seen, especially when you have multiple cancellations for whatever reason. So I can take your information once we're finished and deep dive into what's going on and see what we need to do to get you back in earlier. Okay, yes, sir.
I had virtual appointments as well.
Mhm.
And those messages you text me and all that. And on my day of my appointment, I get a link.
Okay.
Message, say, hey, appointment's coming up today. I can do that sometime. I didn't get anything. And the appointment was done and I had to wait another 3 months to
Mhm.
get another appointment.
Okay.
And that was the primary care. So
Mhm.
like him, I should have been seeing, you know what I'm saying, close to the date. I had to wait another 3 months.
Okay.
just for one.
So what I can do as well, it's the same as I would do with this gentleman. I can take your information, I can pull it up, look at it, see what occurred, and see how best we can work with that provider to get you in sooner and ensure that that link is provided to you. Now, for the video, the VVCs, if you're schedule an appointment, and with these appointments, you are emailed the link and you get the information just as the gentleman said in the back. If you are scheduled for a VVC appointment and you do not get that link prior to, I encourage you to reach out to us so we ensure that that link gets to you. They should be verifying your email address while on the phone to ensure that we can send those appropriately to you. Okay, so let me get this gentleman and then I got you in the back. Yes, yes,
Yes,
sir.
ma'am. For community care, if it's 3 months out, is there a time frame or a specificity that's required that if they're booked up 2, 3 months, can it be referred to community care? How?
Yes, in some instances, yes, they should be referred out to community care, and we are reviewing a lot of those. I know we are working on a project to look at the days for primary care as well as specialty to ensure that once we have reached that threshold, the veteran does qualify, we should be pushing community care. And we are partnering with community care. We are on the same team. We're partnering with community care to ensure that those are appropriately done. We're implementing new training processes for the MSAs as well that we're beginning by next month to ensure that once you leave the facility, you walk away with an appointment where appropriate. Okay. So for primary care, 20 days, and for specialty clinic, it is 28. Yes,
So my
let me get.
question is along the same lines that he just spoke of, and that is that the veteran has to request community care after his appointment was canceled for 3 months. He should have requested community care then.
So they don't necessarily have to request the community care. That's why I say we have training. We are retraining our staff to ensure that where the veteran is eligible for community care, we are offering community care.
Yeah. Veteran also has requested him or herself.
So if they do request it, then definitely, but
Process is faster that way.
there you go. But even if not us, him requesting or the patient requesting, once we reach that threshold and determine the eligibility for the care as well as the veteran qualifying for that community care, then we should be offering. Again, we are pushing a lot We are, with our leadership in health administration, along with Dr. Lee, we are pushing a lot for training and beyond that, the accountability to make sure that we are providing the care or the access to care as we should.
I'm sorry.
Go ahead.
Schedulers on the phone are authorized if you ask them to refer you to community care and set all that up. Or do you have to go back to the referring doctor?
So the staff we have two sets of staff. We have the consult team, we have the regular patient scheduling center. If they are not able to do so, they are not going to cold drop you to another person. It is a warm handoff to an individual who has the capabilities to do so. And again, for the scheduling team on the phones, we have been doing for the last month, extensive training. These are new staff coming aboard that we have hired to come in, answer calls in a more efficient and timely manner. So you're not holding on the phone, 3, 4, 5 minutes. So these staff will be starting next month. So where they're not authorized to do those, they're going to do the warm handoff to an individual to ensure that they address those for you. Yes, please.
So just to kind of piggyback, so last couple of years, and I get there's a lot of changes, this all leads to the question I had. Oftentimes in those scenarios, there is manipulative language that's used by the schedulers to try to, and I understand you guys have metrics you're trying to meet and all sorts of things, but to try to steer you away from booking through community care. Because that, I'm sure that comes out of a different bucket of money. And so is that one of the things that's going to be addressed in this new training? So that so the second I ask, I don't have to do some little circus dance with somebody that thinks I'm stupid to try to obtain that appointment to community care, which is well within, the range of time frame,
Yes. So we're removing those barriers with the staff to ensure that the language is clear, not just for you, but for the employee as well. We've also placed in measures in place that if they're not truly understanding what you're asking for, they have a next level supervisor to now take that call and address that appropriately. Okay. Yes.
Yes, ma'am. I understand what you're saying.
Mhm.
And I know that you want to move on,
Oh, no, you're fine.
but that's not been my experience as late as this week. And maybe it's because I was operating through secure messenger as opposed to the phone. I was going to community care for sleep medicine. The provider closed down. I sent a secured message to community care and to the sleep clinic at Arcadia. My message said I was previously seen by a community care provider, and I named the provider for my sleep apnea care. Their office closed. I don't know if I need to return to the Arcadia Sleep Clinic or community care to continue my services. I have my CPAP machine. I have my supplies. I just need a provider. Please advise. From community care, once your PCP puts in an order, then we will find you a provider for sleep. From the sleep clinic, it was the same. My PCP has to put in a consult. Why does my PCP have to put in a consult in order for me to go to the sleep clinic when I've already been seeing sleep medicine?
So, Dr. Hollis, community care, that's a community care question in a sense.
We are not allowed to refer out on our own. So it has to start somewhere, which is the primary care. I'd love to see who answered you though. So that looks like I've got some education to go along with because it looks like they did not respond to you appropriately. So I would like to see who responded to you on that. But what should have happened is the AMSA should have stepped back and said, nurse, I need you to take a look at this for the veteran. We have care coordinators in community care, and the AMSA shouldn't have tried to hurry up and answer you. They should have gone into your chart and looked, saw that you had a previous consult, saw that you had received care. There's not a new consult to continue care. Nurse, I need you to step up. So that's a miss. So I apologize for that. That I'll take responsibility for, and I'd love to see that message and see who responded, because I've got some care to take for that. Now, for the Arcadia Clinic on the internal part, they are also not allowed to consult themselves. But I don't know why they would have responded in the same manner. I would have to say we would have to forward that to the sleep medicine team and let the providers respond to what's going on there in their department.
Okay. The referral under which I was seeing the previous provider has not expired.
Okay.
But in order for me to go to another provider, you're saying I need a new consult.
So your consult is still active. Who canceled your appointment? The internal Arcade or the sleep medicine team or the provider in the community?
I shut down.
In the community. So you're looking for a new appointment.
I'm looking for a new provider. Or I can go to Arcadia. I don't care. I just need someone to care for me.
So the community provider is no longer in service. Got it. Okay. So I think that the AMSA misunderstood what you were asking for. I'd love to see that, and we can talk after this so that
And
we
that's
can look
why
at it. Yeah. Yeah. We'll do it. Thank you.
Sir, any other questions for HAS?
I want to say this, and it's not a dig or anything against community care. I love my VA care. I do. My problem comes in when I am moved to community care, because it's always some sort of issue, and it's not within community care. It's all the hurdles that I have to jump over. I have to go back to my doctor, get a consult. Community care, the people I talk to on the phone are great. They help me get hey, do you have someone you prefer? No, I don't. Let me find someone in your area. Great. Love them. Then I go to that person, just like with my CPAP. The provider says, I can order that for you. And no problem. I bring the prescription to the VA. Oh, no, ma'am. He can't do that. We have to order that for you. Okay, fine. But then it takes you a month to get it to me. Why? And I stop breathing 19 times an hour. Why? And then I get the CPAP, but the mask has to be ordered from somewhere else. So I got to wait on the mask too. If you're going to send me to somebody, it's somebody you vetted, trust that somebody to give me the equipment or the medication or the whatever else I need, and let me have a smooth transition. But I can't get that. I don't mind going to community care to get my care as long as I get it. But why do I have to be the one to, and I have the secured messages from that transaction. I can't be the first person to go to sleep medicine in community care. And it can't be that hard for everybody. This is not new. So why did I have to go through all of that? I love my VA care. I love my provider. And like I said, when I talk to the people in community care on the phone is great. Right now, I'm dealing with not being able to put in my travel for another issue that I'm dealing with, my physical therapy that I'm in community care for. Why? They said, oh, well, you can put it in by paper. Uh, the travel people here too. You can put that in by paper. But you said you don't want paper anymore. You want us to do it online. But my appointments aren't even in the computer. Community care, they're not even in there for me to do it online. So that's just, I'm sorry.
No, no need to be sorry. I do apologize that that's your experience with the, I know Dr. Hollis is taking care of the community care part. We will also address with the travel reimbursement portion before you leave as well. I do have someone in the back that will address the other deputy that's here that will address that with you to ensure we get that taken care of as well.
And we can also address the other issue related to supply chain management and the breakdown in that system. What I will tell you is, one, we're sorry, and that doesn't help in the moment. But what I also will tell you is, in the past, a lot of our teams have been siloed. Everyone's working in their own section. The reason why the Access team is what it is today was because each of these groups were under a different ELT member and they weren't really collaborating. Now that they're under one ELT member, we are working to build processes where we can better collaborate and work across the aisle to remove those barriers. Because barriers that you have are sometimes the same barriers that we have internally, and we need that support to get the changes. So now they have someone advocating for them to say, hey, this is what we're seeing on this side, this is how it's affecting this side, vice versa. And I can have those conversations with other ELT members so that we can then find solutions that can last long-term and be sustainable. This should have happened a long time ago, right? So that's not lost on me at all. However, I'm here now, and I'm going to fix the things that are brought to our team. And we collaborate on a regular basis to have these conversations. As you bring them to us, as we discover them ourselves, we are working on that. So ideally, by the next time you see us, we're going to have some additional things that we've changed, additional things we've improved on. And we want to track this over time for us, but also with you all, so you can see the changes that we're making, see the efforts. And if it's still not working, you can give us immediate feedback so that we can go and address that as well until we get it right. So we appreciate all of your questions. We appreciate your time. We appreciate you being here because we do want to see the same changes that you want to see. It is going to be a team effort, but we want to show you that this is what we are aspiring to and that we're going to get it done. So there's no excuses, none from us. We're gonna resolve the issue and then we're gonna work on fixing it going forward. So this is not a continual thing going on. And what happens to one person probably happens to other people, and that's just unacceptable for us. So thank you for bringing that up.
Okay. All right, the next person we have is Miss LaWanda Knox.
First, I would like to start off by saying thank you for your service to all of the veterans. I am LaWanda Knox. I am the Associate Group Practice Manager at Atlanta VA, the only one right now. But today I would like to discuss with you what we are doing to improve access to care for veterans. We are reducing wait times by reviewing provider grids and identifying any additional appointment slots that are open so that we can make sure that we fill those slots with veterans as soon as we can. That way that we can decrease the wait times. And right now, we are striving to provide appointments in accordance to national metrics. For primary care, it is our expectation to meet the goal of 20 days from the time that you request your appointment to the time that you get your appointment. It should be a 20-day time frame. For mental health services, it should be 20 to 28 days. And for medical specialty, you should have your appointment within 28 days of the time you requested it. But At this time, we are a work in progress. We are working to get to these metrics. Okay. Another thing that we're doing is reviewing consult timeliness. At this time, we are reviewing all of our open consults as well as our pending consults at the facility. And the group practice management team, along with HAS, community care, as well as the clinical services, are building teams to review these pending consults. And as you can see, in November, there were over 3,700 pending consults. As of Monday, we only had 2,505. So these numbers are decreasing. The numbers do fluctuate from time to time. It just, depends on what's going on within the facility and, how many people are requesting the different types of care. And I have been working with HAS with Ms. Daly and her team, and their numbers fluctuate with the active consults that they are trying to get scheduled so that, everybody is, receiving that phone call to get an appointment scheduled or to call us back if, we're not able to reach you at that time. The next slide, please. The other thing, and so the other thing that we have is open slot management. With open slot management, if a veteran has an appointment and they cancel the appointment, it can be offered to other veterans. And I want to say it's the veteran that has been waiting the longest to have an appointment with that particular clinic. And as we started using open slot management in 2004, we did reschedule a total of 3,000 appointments in, 2024, not 2004. And in 2025, we rescheduled 7,000 appointments. And in 2026, so far, we have rescheduled 2,000 appointments. And things we need from the assistance, from with the veterans. So our no-show rate, Ms. Daly did speak about the no-show rate for the facility. So some things that can help lower the no-show rate are canceling your appointment. So it can be offered to someone else so that that appointment isn't there. And also updating your telephone number, vet text, through vet text and secure messaging. And what else was on? And yes, also keeping your demographics updated. If we don't have the correct telephone number for you to offer you a earlier appointment slot, you won't get the message if your telephone number isn't updated, as well as your email address. So if you could keep those things updated, and I really would recommend keeping those updated through secure message, because I'm thinking that's probably the easiest way to get it done. Or if you're at the facility, before you leave, each time, just make sure we have the correct telephone number, email address, as well as your home address, because we may even send something in the mail to you in regards to your appointments, and you may not receive that as well. Mr. Bruton.
Right, Mike. Good afternoon, everyone. My name is Gary Bruton. I am the West Regional Administrators for the healthcare system. I am from Blairsville to Noonan and from Cobb over to Carrollton, 10 outlying sites. Mr. Sam Miller has the East region has 11 outlying sites of care, multi-specialties at Atlanta VA Clinic, as well as Pike Clinic was mentioned earlier down in Zebulon, the large Fort McPherson outlying medical center, as well as many of these other CBOCs that many of you may have visited. Again, talk about the organizational realignment. One of the things we've done recently is we moved all the contracting activities under the regional offices to try to get a more timely response, taking authority over that with the contracting officers for NCO 7. A couple things that they have mentioned, moving the gold team from the Atlanta VA healthcare system to ABC. Got a typo on that. Pain management moved to ABCS, and mammography moving to the pain clinic area. Also, the echo clinic from Atlanta VA healthcare system to the Pike Clinic. So we are expanding some clinical services to our outlying sites of care. These. All right, so the West region, as mentioned, my office, I hail out of Carrollton, Georgia. Go Trojans. Anyone? Okay. They were in the state championship. Lost to Buford. Anyway, Trinket Davis Veterans Village Medical Center, as well as a large monthly specialty and a 42-bed community living center. Again, all the way up Blairsville and Rome, down to Noonan, or Seabox, in Cobb. We have South Cobb, West Cobb, Big Cobb. Lots of Cobbs. A lot of reason for that is we have a large number of veterans in that geographic area, and we try to put many of the primary care and some specialty care services, high volume specialty services, as close to the veteran as possible. So again, we had the organizational realignment. This really, from an operational standpoint, helps us. We don't have to go through second and third parties. We're able to deal with the contracting officer and with the lessors immediately for any issues that take place at our CBOX. For those of you that don't know, the Atlanta VA, Fort McPherson, and the Trinket Davis Veterans Village in Carrollton are the only VA-owned sites of care. All the other ones we lease and are contracted. So we have to deal with contracting and the lessors as we go through that. West Cobb in particular, we had a grand reopening recently. It was well attended by staff, employees, and I think we had 60 plus veterans there at the time. We did have an issue there. Some of the cold weather in particular, burst an internal pipe. And then, you know, it never happens right there when the staff is on site. It always happens at night when nobody's there, and we walk in the next morning, and there was lots of water on the ground. 17 rooms were compromised. I think we pivoted extremely well. We were able to then open up exam rooms at Big Cobb, which is located about 6 minutes away. We're able to pivot all the veterans appointments over to Large Cobb, and they were seen there for 2 weeks while we got this mitigated as quickly as possible. Yep. Trinket Davis, couple issues, exciting things going on out there for increased access. We're the only ones right now that I'm aware of in Georgia with a mobile lung CT. So we're in the process of getting it hooked up at Carrollton proper right now, getting the fiber optic run. And once we get that done, we get it up and going, see patients there. We'll be deploying it north and south to the Rome Clinic up north, Noonan down south, a couple days a week between those two locations. As I mentioned, we had a 42-bed community living center. They're going to be breaking ground. I don't want to be committed. I'm told March or April. The project's going to be completed July 2027. We're going to add an additional house. It's a greenhouse model, and it will have 12 more beds. So we'll be able to have 54 total veterans in our community living center out there. Is that it? Any questions regarding the outlying sites?
What are we supposed to take away from
So
Expanding care.
that? Gotcha.
in addition to that, it also helps you understand some of the things that go on. So for example, West Cobb closed, appointments would have been moved around, but we want to let you know it's now back open, what happened, why that happened. And then again, while you're here, if you did not get put back in West Cobb and that's something you want to do, you can get with our staff here so that we can make sure that we're putting you back to your closest facility. Because we do know that that was a concern for a lot of veterans. So one of the things that I try to do for all of my staff is really share what we are doing to impact access across all of the areas that fall under the office of the AD. And sometimes it's not always, like you said, obvious. And so part of that is for us to better understand why it's obvious, why it makes sense, and then to be able to convey it to you all. Because again, if we can't share it with you, then we're not moving in the right direction. So we are very much a team. We're moving forward as a team. And so this is one of our efforts to have that team concept and move it forward. So thank you for that question. Yes, ma'am.
First question. You guys use a lot of acronyms. What's the CFOP?
Community-based outpatient clinic.
I have long since said that the care needs to be spread out because everybody it's not convenient for everybody to come to the
Main campus.
main campus.
Yes, ma'am.
But when you say this was moved to here and this was moved to there, do you mean moved or added?
Added. So we still have all of the main care here. You can get everything in here. This is the hub. However, what we're looking to do is determine what additional types of care is appropriate at what locations. Part of that's dictated based on the amount of space that we have in a particular lease site, our ability to get providers there, things of that nature. In addition, your care sometimes requires additional services. And if we can't provide that in the same space, it may not make sense to put it there. So we don't want to put a veteran in a situation where they wouldn't be able to get everything that they need as much as possible within a general region area. So that's why we're mindful and kind of slow to move things out. But we are having those conversations because we agree with you. We need to get care to where the veterans are. We are currently doing a market feasibility study and a market assessment. Both of them, the goal is to determine where else we should go, how we should look at moving around our footprint. After we do that, we still have to get support from Congress to pay for that and actually make it come to fruition. But that we do review that at least every 4 years to look at the growth that we have in the market, where we should be going. We're actually looking at expanding in Gwinnett as well, that area. We do have a lot of veterans out there. We're aware. We're just trying to get the support and figure out the best way to get out there, whether it's lease, whether we need to buy something, whatever the case may be. So right now we're in a unique position. Congress is very aware that Atlanta is growing and growing rapidly. We tell them that every chance that we get and can get. But we are also mindful of having to share the same pot of resources with all the VAs across the country. And so we're going through reviews to see who's actually going to get money in the next upcoming years, how much and for what. So we're working on that. But yes.
Next question, you said mammography is over in the pain clinic area now?
Yeah, so we're expanding our mammography. It should be, I believe it's gonna be over by the Plain Clinic. It is not open yet. We had to get a new provider. So there are some hiccups in it, but we are opening that. And as we're moving that forward, we will share those updates. But that is what we're working on and moving towards that.
Okay, as a high-risk patient,
Yes, ma'am.
I have to be seen twice a year.
Mhm.
Will I have to come back from community care to the VA to be seen for mammography?
So the way they're gonna set up the clinic is a slow open, right? So they're probably gonna start off with a test case of veterans that are not high risk to ensure that we have what we need. We're able to open the clinic. We've tested everything and it's working the way it needs to. As we expand the program, then we'll look at acuity and then start having that conversation of care and who needs to come back and whatnot. But that is not gonna impact you right now. first we want to get it open, make sure it's up and running properly before we start making any major changes like that. So it'll be a small subsection of our veterans that are start getting care there first, and then we'll look to expand it over time.
Thank you.
You're welcome. Yes, sir.
Mine is more of a suggestion. I'm new to the VA healthcare system. I had my first primary care visit with my physician, which took a while to get in, but it was back in October, I think. You're allotting 30 minutes for any physician or physician or anybody you see to see you. He spent 30 minutes filling out all this online questionnaire and paperwork, and really, I had 5 minutes to talk to him about it. And I've had a follow-on visit. It was a video visit with him. He spent another 15 minutes, 20 minutes of our conversation going through, asking questions that, do you feel depressed? Do you do this? Do you do that? They're basic questions that everybody asks you. Why can't that be done upfront by me on a computer, on a laptop, prior to my visit? So those are all out of the way. He can review them, and then he could spend quality time with the patient, assessing the cares and needs that they came there to address. As the 2 visits I had, nothing was really addressed. They just, we'll schedule other meetings.
Okay. That is a great suggestion. What I'll do is I will take that to the chief of staff, because that's more of a provider. The providers will have to make those changes, but that is a very good point, and I will take that to the chief of staff. So what we can do is we'll look to have somebody here next time that can address that. And we can get.
It's a suggestion. I mean, I'd rather spend 25 minutes talking about my real issues rather than 5 minutes and the rest of it answering questions that are required by you guys. And it's fine, but they can be easily addressed with an online form. Sit in the office, give them a tablet, do it on a kiosk, whatever the case may be, and they fill them all out.
That makes sense.
Or even you're sitting with, prior to my appointment, I sat with a nurse practitioner who took my blood pressure and all that. They can ask the questions.
Let us get with the chief of staff and their team, and we can get you a response for that. Great point. Thank you for that. Anybody else? Yes, sir.
Legal assistance.
Legal assistance. So the facility does not. Usually if you need legal assistance, you can reach out to veteran service organizations, and they have some resources that may be able to get you some legal assistance and be able to work with you. You might be able to.
I think, you could probably go to volunteer service.
Yeah, that's what I was gonna say. The Center for Civic Engagement, Civic Development and Engagement, CDCE, aka Voluntary Service, they also will have some resources. They're not far from here, so we can walk you over there after this to make sure you're connected with the right folks and see if they can support you.
EOT?
Yeah, Executive Leadership Team.
Okay, ELT.
Yes,
Okay.
ma'am. So thank you for that. I know we had one slide talking about acronyms. This is something we're genuinely going to work on. We do use a lot of acronyms, so if you don't know what an acronym is, please raise your hand, let us know, because this is the life that we lead, unfortunately. But we want to get better at being mindful of that, so that's why we at least had one slide, but we can start adding some more. Just for future reference, we'll probably keep it at the end, and just make sure we have them all in there. But if we miss one, please let us know. That is something we're trying to
The
work.
worst thing is going from the military to the VA and the action between 2 totally different things.
Right.
Yeah.
Well, maybe a Mackie at the beginning of these, while everybody's waiting for you guys to show up, would be great, so that we can familiarize ourselves with what these acronyms are.
We can do that.
We can start.
No, I think that's a great
Some
idea.
of it.
We can do it at the beginning and we'll have one at the end. So if people come in early, you can look at it. And then at the end, we can have some additional pages at the end. So that's not a problem. Great idea. I appreciate that.
For community care, and providers. Who's responsible for getting the records from that provider to VA? Does community care do it? Do I have to get them?
So I'll let Dr. Hollis, that is the bane of her existence. So I will let her answer this
You
question.
guys are beating me up today. Oh, ooh, this one's a sore point for me. Ooh. Oh, yeah. So there's a couple of problems with medical records and how we get them. So first part, yes, you go out to the community. Community care should get the records. All right. It would be easy, but it's not. I mean, I cannot tell you how many times I sit down because I hear my team say, I'm having problems getting the records. But then the doctor calls and they're like, here you go. And I'm like, wait, what's going on here? So I actually sat down this past Monday and worked it because I had a couple of team members that said I'm having problems, but I have a provider that said, no, I'm not, I don't experience that. And so I worked it and I called and the provider picks the phone up and I said, hey, I need the records. And she goes, who are you? I said, well, I'm Elizabeth with the Atlanta VA and I'm trying to get it because we sent the veteran for the care. I'm going to report you. This is a HIPAA violation. How dare you call and ask for those records? I can't. So I ended up sending it to Optum and they're like, okay. So it's a multitude of issues. We have many ways that we can receive records. We're trying to streamline it so that we can get it in. So this is a huge sore point for me. So because we can get it in 5 different ways, 5 different methods, and there can be single points of failures in there, plus our eStream fax that we have is old, and it breaks down 1 to 2 times a week, we get interruptions in transmission. Excuse. So I'm working on it. So the second piece is when we call to ask for the records, that's what we're met with. But when the doctor calls for the records, they're going to give them the records because the doctor's on the phone saying, I need provider to provider. And the other doctor's like, hey, send those records. And then they get the records and they're like, we don't know why you couldn't get the records. Some places have set it up to where community care can't even talk to a person. We call in, we leave the information on the line, tell them what the authorization number is, and then we're begging for somebody to tell us what's the information, just tell us. So should we get the records? Yes, we're trying to get the records. So we do what's called a request 1, a request 2, and a request 3. And then we will admin complete. And that's usually when the providers internally start nutting up and saying, oh my God, we didn't get our records, and they get upset. And so then we try and continue to get the records. And then the provider is also trying to get the records. And, it's just difficult. So if you have the records and you bring them in, then you take them to the clinic. The clinic goes, oh my goodness, thanks. And they send them over to HIMSS. And then you're like, where are my records? I brought them in, but they're lost. Where are they? Did they go in the shredder? Did somebody send them? Are they in email? Who knows? So what I'm trying to do is work with a new company that's out there, and I'm not going to release their name because we are recording. And this system that I'm looking at is expensive, but I think this is where it's going to benefit the Atlanta VA. And I'm putting my proposal together because as soon as you fax the system, that Autobot picks it up and immediately uploads it. And you don't have to have a human to do it. It'll raise its hand for a human and it'll send it in. But I don't have a straight answer for you.
Happen online, I have the records, I scan them, I can upload it to you.
If you send them through secure messaging, wonderful.
I mean, the answer I got from my doctor was, bring it to the office, tell them that this is to be put in your record, not give it to the doctor. They put it in an envelope, they send it here.
And then where does it go?
Yeah, and I don't know if it got here,
So the system that I'm looking at for my proposal is one that requires only one fax line. So I am trying to negotiate and propose that we go to one fax number so that if you take it into the clinic and it gets faxed, it goes to this system and it uploads it. It never takes leave. It doesn't go on vacation. It doesn't have kids. It doesn't need FMLA. It doesn't need breaks. It will upload it. And I think it is a solution for the Atlanta VA to get the records that the veterans are bringing in because this is not a unique complaint. And so I'm really trying to resolve a portion of it with Dr. Lee for the whole facility because I believe that's the right thing. But in a nutshell, should community care get the records? Yes. What happens when I don't get the records? We do an immediate outbound call to Optum, and I put in what's called a leaf ticket, and I let them know, hey, such and such hospital A did not give me the records. I spoke with so-and-so, and she lit me up and said that this is a HIPAA violation. Optum then outreaches them and reminds them of their contractual agreement. Now, how long do they have to give us the records? So we will do the request for records 1 and wait 14 days for the records to come in. Unless it's a stat and there are other caveats there that are built in. And so 14 days, but in the directive, it's set, or in the, what is it? In the field guidebook, it says the veteran or the vendor has 30 days to send it, but yet Optum is saying 14 days. So which one are we doing? It's actually 14 days for Optum before I can report the vendor as non-compliant. So that's the thing. And then if we don't get the records, I'm required to have a list that we've admin completed, continue to try and get those records. And then I have to take that list and report it to Optum and tell them these are the non-compliant facilities. And then Optum is required to follow up with them to find out why are they not getting their records. And we use Optum a lot, especially this year. I've learned a lot about medical records, the responsibility of community care, the responsibility of Optum. So is it good and clear cut? Nope, but I'm working hard on it because medical records is your care. And we need that medical record for more care to occur or to find out if something else is happening. I need the record. And so I'm hoping with Optum in the next gen contract as they build for the next go round, I'm hoping that somewhere in there they may change the language that you need to send to you will send the records. And I would love for that language to be changed, but I don't make those decisions and I'm not at the table for that, but we have definitely verbalized our discontent for it. So we're hoping it'll change from you need to send to you will send. We're also hoping it'll go more towards you won't get paid if you don't send the records. We would love to see something of that nature, but we don't know what's going to go into that next gen contract with Optum, but we're really hopeful that they'll help us. Somebody help us. Yes.
We have to talk about records internally as well. So go ahead.
You mentioned secure message is an option to send it. I'm assuming we send it to community care admin, and is there a specific language or verbiage to put in there that here's my record for this consult visit?
Nope, you can say, here's my record. Could you please assist? Done. We'll go in and take a look, see if you have a consult. If the veteran doesn't have a consult, we will immediately take it and send it to HIMSS. HIMSS will then grab it, take it, and upload it and do what they need to do. Yep.
That's why I wanted to bring things up to kind of speak to their process as well.
Is that another question for medical records?
How do you get new providers into our community? I went and I had a good experience with one, and maybe I think the other veterans would have, like, how do you get new providers into, like, do we recommend them to you all, and where would we go to do that?
No, so the provider, if they're interested in coming into network with Optum, they'll need to go to Optum. And there is a provider line. So, they can go to Optum's website and there is the 1-800 number there and they can email them, send them messages, let them know, hey, I'm excited, I'm a good provider and I'd love to come into network with you and to be, offered the opportunity to serve veterans. And so depending on the network adequacy, that's what determines if they'll come in network. So let's say we have 60,000 acupuncturists and this will be 60,001. They may say, no, we have adequacy at this time, but if anybody drops from the network, we'll consider you. So, and to get into the network, it takes a minute for the paperwork to be done. So I have had veterans that said, well, I know that my provider has applied to be into the Optum network and it's been 3 months and I want to be scheduled, but they're still not in network. But I only want to be scheduled with him and you need to give me an appointment, but they're not in network and I can't authorize the care because we don't have any means to pay them. And so it can be a lengthy process because if you miss any step of the way, like most government stuff, if you miss any block, it delays the next step. And so they have to make sure they're following up and they're asking Optum, what's next? What's next? Where am I? And that's for the provider to do. But we've seen it take from, 3 months to 6 months for a provider to come in network.
What about the opposite experience?
For, what do you mean the opposite? That they don't?
You have a bad experience.
Oh, if you have a bad experience, you can send us a secure message and I want you to be detailed. because then my team members should pick it up. And most of my team members, if you say, I had a bad experience in the community, they're not going to put it to you. They're gonna be like, oh, Dr. Hollis, you take it, because they're not going to answer it. And then what happens is we will have a vendor relations team member outreach you, and we're going to ask you, we see and hear you said this happened. We see and hear, I mean, we've had veterans come back and say the office was filthy.
I literally had to fire a provider.
Mhm.
I refused for that.
Okay, and so we would need to know your experience, because then what happens? We can't take them out of network. What we do is we follow the Optum process, and we take your statement and we upload it to Optum, and we put in what is called a PQI. Cannot remember what the acronym stands for. Oh, anyways, it's like a reporting system, and we let them know, and they're going to ask for a couple of things. Who's the provider? What's the MPI number? And you don't need that. We get that. What's the address that it happened at? What is the concern of the veteran? And then they take it from there. And so Optum has removed vendors from the system and completely blocked them, dropped them, because they get a lot of actions. They have to prove back to Optum that this didn't occur, or no, we understand the room wasn't to the best. Our cleaning person didn't come. This is how we're going to make it better, blah, blah, blah. And Optum will audit. Okay, so they do a lot with vendors. So all we need to know is that you had a bad experience. What was it? I mean, it could have been a bad experience with the front office person, and my vendor relations is going to call over and talk to the office manager and say, the veteran had a bad experience. Tell me what happened. But do know it works both ways. So if you go out in the community and we have a meltdown, my husband had a meltdown, and they reported back, and I was like, you cannot do that. So it's hard, because I watch him bite his teeth, and he's just like, oh my God. But you just have to remember, try and stay as calm as possible. Try not to, give back at what you're receiving, and allow them to do what they're doing, and then immediately report us. But we have had veterans that have been reported on for bad behavior in the community, and that resulted in, a review of, are they appropriate to go to the community? And we can't restrict access, but it definitely makes us on alert of what's happening here. All right. And so, we don't want that experience to come back on you. So just know that is a two-way street when it happens. We don't get it very often from our veterans, but when we do, it's bad. So, okay.
Just an observation to the provider search on the VA website. It works on mobile platforms, but you go to the website and it says we're going to work it. And I've checked back several times.
So, I'll do a PAO team, because they actually own the website and manage it, and we'll check into that and find out.
It's on my mobile device.
No, but we should be able to fix that.
Yeah.
We'll get with the team and find a solution, and then we can show it next time and make sure that it's working. That's not a problem. But go ahead and tell them how we do, internal records.
For internal records, I know for quite a few people, they'll walk up and bring it to the HIMSS location and say, hey, I need this in my records. The best possible way to get your records, any records that a provider has asked you for, is either one, you can send it to the provider via secure messaging, or when you come to your appointment, you bring it to your appointment, or you take it back to that provider, because the provider has to review it and determine what it is he needs that's appropriate to your care that they saw you for, to add it to your record. And then there's a specific way that they do the routing to get it to HIMSS, which is our health information in here. Management, CERTs. So yeah, we use acronyms and we say we don't remember them, but that way the appropriate documentation gets to your records that's appropriate to the care that you are receiving. And I do know a lot of time you have disabilities and you want to make sure that records from either military or other things are in there. And if the provider is asking for it, yes, by all means, get it to the provider. But there is a process. So just showing up down on the ground floor to just say, hey, I have records, I need it uploaded. No, it's the provider needs to dictate, because there's certain notation that has to go in the system to ensure that that HIMSS department uploads those records to the appropriate documentation.
Could you say that again, like I'm 4 years old?
Okay, so if you're coming to your doctor's appointment and you know you're coming in for back, you have records on your back and you want the provider to review it, add it to your records, whether it be for disability or just you want him to have a copy of your records so they can provide the appropriate care. Bring it to your appointment. If you don't have it and you have to bring it back, you can one or two things. Either use a secure message and send it to your provider, or you can bring it to your location, to that particular location, the provider, so that they can review all the documentation. They have to review it before the HIMSS, the medical records department can upload it to your, or scan it to your
Because
records.
they're required to put in certain notes to make sure it connects to the right place. So it's not just in limbo, but it gets to the actual provider that needs to review it and they can actually see
And this is for internal use, so this stuff isn't automatically mapped out?
So,
Like, if I go see a doctor today, shouldn't that be entered in?
no, if you're bringing something from outside, say for instance, you didn't go through community care, so maybe that's the piece that was missing. Yeah, so that the in process, not community care, that's why she said internally. Now, when you see the provider, yes, if I write it, she sees it, anybody, yeah, we can see it. But it's like outside of records, maybe not associated with community care or anything else, and you
Whatever.
want to add it.
Yeah.
Okay.
Any other questions? Well, I want to open it up. First of all, I want to say again, thank you all for coming. Thank you all for the questions, the conversation, the feedback. We will definitely take all of this information back and use it. But we most importantly want to make sure that we provide you updates and accountability going forward. So that's what these access forums are for. Please tell your friends, please tell anybody you know that needs to come, that wants to come, that has questions to come so that we can address their concerns. If they're not getting through, if they're getting frustrated, that's not what we want. We want to provide them with direct access to the people that can make, that can remove barriers, solve problems, and get them answers. And that's what these sessions are for. This is our next forum. We do it quarterly. Now that doesn't mean you can't reach out to us before that time. I would like to say part of the reason why we emphasize secure messaging is because we have about 500 employees on the HAS side, Health Administrative Services, and that's not all MSAs. They're not all schedulers. They're doing a plethora of things. We have about 200 employees on the community care side. We're getting about 22 new enrolled veterans per day. So in addition to your care, you got 22 people that are added on every single day. And we're not adding on the same or the equivalent amount of employees at the same rate that we're adding on the veterans. And so that does create some barriers. So as we're improving processes and making changes, as we're improving our communication and solving problems, removing barriers, we're still having the same number of FTE that we've had. In fact, we've actually increased our number of FTE in HAS. I think when I started about a year ago, it was it was less than 500. So at least we're now to 500 in HAS, which is a big change for that group. So that's not, again, not an excuse. We're just trying to put it in proportion. And that's why we've been emphasizing secure message so much. But that is not the end all be all. That's not the only way to access us. Like we said, we have these forums in place to have these direct conversations. We're adding information to allow veterans to be more proactive and so that we can communicate with you guys more proactively instead of reactively online. And so again, thank you for coming. If you have any additional questions, we will stay around for a little while to answer those questions, to meet with you, talk with you. And so again, thank you so much, and hopefully we'll see you at the next time. Yes, sir.
Yeah, I asked the same question. So it's supposed to go out with all the announcements. There's supposed to be a link there.
Yeah.
And I think one of the things is they want to encourage folks more to show up here so we can have the direct stuff because we do have staff that can help you one-on-one.
Yeah.
But we'll make sure that link gets pushed forward, just like in our Veterans Town Hall and our Women Veterans Town Hall.
But this will be uploaded to the thing.
Yes, we have a VA Atlanta YouTube page. And that's the way it's labeled if you Google it, VA Atlanta YouTube. And once we get done with this, we'll go back and over the next couple of days, I'll put it together and we'll upload it to that YouTube page.
Yep. Yes, sir.
This meeting in the town hall, it's just like a little more to.
So this is specifically access concerns. So when you,
Access to care.
yes, so community care and internal scheduling consults, things like that. So at the big town hall, everyone's there. There's more presentations. You know, it's a different forum and it allows anything. So if you wanted to talk directly to the chief of staff or their or providers, they'll be there. But this is specifically addressing the access concerns because we know that there have been so many problems. And again, we as a team are proactively addressing those and trying to outreach our veterans to improve. So that's the main difference. But we are also at that location. So if you want to come to that one, if that's better, feel free to come. We just want to provide more opportunities, especially if you have unique situations or individual things that you want to take care of. We have the folks there on site to be able to do that. Yes, ma'am. The next one? Yeah. Our next one is April 30th.
Next town hall is in March. I believe it's March 16th, and it'll be down in the Pike County Community-Based Outreach Center there.
And so
we are going on the road with those.
yes, with that one, originally they were only here at the facility. But again, to another young lady's point, everyone doesn't want to always come downtown. And so we are trying to move around to the different outpatient clinics to allow veterans who are further out to still be able to come to a CBOT closer to them to get the information to be involved. Those are also streamed. So if you can't come in person, because that's pretty far, you'll be able to stream it. But we'll make sure that we do a better job of getting those links out so everyone has access to it. Any other questions?
I'm willing to give you my address and my date of birth. Because what they're doing is a 2-patient identifier to make sure they've got the right veteran and the right chart pulled up.
So it's more, I have no choice.
So,
So that needs to be reported.
so let me address that. So we had a extensive training and some redesign and changes as far as veterans identification. So all the MSAs have been trained. Yes, they do have to identify you. You can show your government ID, your full name, date of birth, telephone number, address, military ID, as long as it's not expired, could be a passport. But no, they will not ask you. And if that is occurring, ask for a supervisor. Any location you go to, anywhere across Atlanta VA healthcare system, they ask you for your full social or your last four of your social. You can stop the line right there and ask for a supervisor immediately. I beg your pardon? We started pushing that really hard in the last quarter of FY25 when we started holding staff accountable, ensuring that they had the training across the board. That's not just for MSA at the front line. That goes for providers, nurses, and all that. Now, I can't speak for lab where they ask for you're in an enclosed area anyway. So as far as lab, I know they may have certain ways they have to ensure that we're pulling. So. But if it's across the board, especially you standing out at the front, full name, date of birth, government ID, address, telephone number. So if you saw my name up there, you have issues, can I speak to? And I'll just put it out there because we are really holding people accountable for that.
So that, in some instances, and I have my own frustrations, but in the last probably year or so, there's been a lot of positive change here that like 5 years ago would not even have been close. So I'm appreciative of all that, but there's still a lot of shoveling to do. But there are instances, especially when you're working on the telephone, where there are some special employees that will just hang up on you when you ask for a supervisor or whatever, but you're saying you're the person to reach out to in that instance.
And if I'm not the supervisor over that, I will get you to the chief of that location.
And so sometimes you don't always catch the information of the individual you're speaking to. So are there any tools in place so that, you know, if they only give you their first name or what, like, you don't always have of who you were speaking to? Are you guys tracking phone calls or anything like that? Okay.
That is correct. If
Okay.
you call into any one of those lines, like for the patient scheduling
So
center,
you
you're
know
trying to,
what's happening.
we can go back and pull your telephone number
Okay.
and we can look to see which line it went through.
Okay,
And we're able to identify that.
okay.
So we're trying to make sure across the board, if you're calling inside the clinic, it's a little bit more tricky. However, if you call on any one of the scheduling lines, we have the what's called the ACD line. It's the automated call distribution line.
Mhm.
And we are able to pull a lot of data from that. And
Okay.
that's what we use to ensure that when you call in, you're funneling. You know, when you listen, you hear the phone tree and it says for one schedule.
Yep.
Yes,
Okay.
that is it.
And that's the same for community care as well.
And what about the patient advocate?
They're also on the line.
Patient advocate.
They're also on the same line. Yes. Yes, please.
And so to add to that, again, another part of that, the reason why we have these meetings is so that we can hold people accountable. I don't think we've always had a process to hear where the issues were so that we could go research it and address it. And so we wanted to create that space where we can hear directly from you all and share with you what our processes are so that you can escalate things sooner and more often, because this is a priority for us and these are things that we want to change. Now, everything doesn't fall under us. However, we know the people that it does fall under, and we have the ability to get things to where they need to go so that they can get addressed. And so that's why I'm always in the room at these meetings, because I can take it to the other ELT members who manage the providers and the nurses and the other staff to make sure that the concerns that you're brought up gets addressed in those areas as well. So this is not just to say, oh, we don't do that. We are a team. This is a change in the culture, and culture change does not happen overnight, especially as you said, you know, it's been a lot of change over the last 5 years. It's gotten better, but it still has a way to go. But it took 5 years just to get better.
Right.
And so in order to get amazing, hopefully it won't take another 5 years, but it's going to take some time. And
Well, I
so,
think in the last 12 months, it's night and day, 5 years.
but even still,
Yeah,
it took 12 months to get
Yeah.
there. So this won't be overnight, but it will be a lot quicker. And so hearing from you, having these conversations allow us to address those things a lot faster. So thank you for that. Anybody else? All right. Well, we will be hanging out in the room to get some information from folks so we can follow up, and then we'll go from there. Thank you, everyone.